Well, I appreciate being here. Thank you, Konstantin, for inviting me, and Patrice. I've been with ASAP from literally the first month of starting my career in neurosurgery. And I continue to be amazed at the consistency and the commitment that the leaders of ASAP continue to show. I think the first person I met here was Patricia, I think 26 years ago, and she has not changed. Patrice, Eric, John, I really want to thank you because I know it's, like Jerry said, it's a hard lift, it's difficult, and it was even more difficult during COVID. So I just want to give you another nudge to keep doing it because it's worth it. Second, I'd like to tell you that the reason I survive every day is partly because of two ladies right there. These are our nurses who came down from Madison just to be with you. So feel free to say hello to them, Jenny and Amanda. And they know more about Chiari than I do now. So I want to start by saying that as academic neurosurgeons, we start off being very unhappy about the status quo. We come in and our teachers tell us, well, this is what you got to do, and say, this is what we got to do? What do you mean? What's the evidence behind this? Why have you been doing this for 30 years? And you start to question. So I feel, and we all feel, that our responsibilities as academic neurosurgeons is to advance the field. The problem is that the bigger the advance, the harder it is to take, the more difficult it is for people to believe it and want to change ways that they've had for 50 or more years. But it's also our responsibility to support the advances that we make and continue to try to scientifically provide evidence that yes, this is the way we need to move, or no, we changed our mind, this is not the way we need to move. I don't think there's a topic in Chiari and the Chiari field any more controversial or has stirred up more controversy than Chiari Zero. And so I thought I'd put together a few slides just to show you a train of thought, how to think about Chiari Zero. What is it and what isn't it? And so I'll start by just examples. This is Chiari 1. You have cerebellar tonsillar herniation and a syrinx. That's Chiari 0. You have a syrinx, but no tonsillar herniation. Okay. So that's the typical Chiari 1. 8-year-old with a headache, syrinx, tonsillar descent. Everybody here, it's standard. This is what we do. Be interesting to know how this all started. Who was it that first did a Chiari decompression? What they thought of him when he was doing it? And do we even have proof now that Chiari decompression helps? We don't have randomized clinical trials to show this, but we know because we've tested it over time and time and time. Okay. So before we get into Chiari 0, I want to try to define idiopathic syringomyelia. Idiopathic means we don't know. So idiopathic syringomyelia is when you have a syrinx, like here, with no Chiari, no tumor, no tethered cord, no history of trauma or arachnoiditis. That's an idiopathic syrinx. We don't know what's caused it. So the question is, how do you determine that this is a Chiari 0 or this is just a syrinx with no cause? And the question is, could there be a syrinx with no cause? Most of us feel that no, there couldn't be. There has to be a cause, but we just haven't gotten to it yet. Okay, so what is it? So the Chiari 0 field really was started by this man. I happened to be his fellow the year where he told me, hey, we have these patients that have syringomyelia and who respond to posterior fossa decompression. I've offered it to I don't know how many residents, and everybody refused to write it. I said, I'll write it. And so this is where the Chiari Zero paper came out of. There were 5 patients, all of whom had Syrinx. Sorry, you have 4 here, but there are 5 here. So that's sagittal view, cross-sectional view, big Syrinx, big Syrinx, big Syrinx. And then when a Chiari decompression was done, this is what happened. The Syrinxes came down in size. So you can argue as much as you want about a headache going away, because headaches are subjective, and you wonder, is he really, is it really true? Is it psychological? But you can't argue with a picture. So this is the father of skepticism, Bureau of Ellis, and that's Sextus. These are 2 people that started really the field of what we call skepticism. Not really dogmatism, skepticism. And it says there are 2 ways to be fooled. One is to believe what isn't true, and one other is to refuse to accept what is true. So it goes both ways. Is Chiari Zero believable? Should we reject it because we've been doing something for 100 years that we're sure is the way to go, with no prior evidence that that's the way to go? And do we avoid introducing new topics because of that? So going back to this, I did a survey, just kind of an informal survey at our AANS meeting just recently, and asked in the middle of a conference, how many of you believe that there's something called Chiari Zero? And how many don't? Bob, how many said they do? 50-50. So it goes to show you that, we're all thinkers. We're all thinkers. Okay. So before we get to Chiari Zero, let's figure out if we understand Chiari 1. Because that's really the gold standard, right? This is what we're comparing it to. So first, the tonsils ascend with age, which means that even if you have a Chiari early in life, you may not have one later in life if you wait long enough. The brain atrophies, that's part of it. So the definition of Chiari 1 has to be placed in context. We can't just look at it and go with a strict measurement without looking at age, without looking at circumstances and previous injuries and things like that. And number 2, there are all kinds of different types of Chiari 1 in terms of etiology, in terms of cause. Some you're born with, some happen after you put a lumbar drain in and drain a lot. Some happen because of a brain tumor or hydrocephalus. Others because of pseudotumor cerebri, increased pressure in the head. Others come in with significant craniocervical instability, as I think Paulo's going to talk about today. There are different variants. Sometimes the tonsils come down, which is Chiari 1. Sometimes tonsils and medulla come down, which is Chiari 1.5. There's inconsistent symptomatology, as Jerry and Errol were just saying. So they're different diseases. It's not one disease. And the reason we don't have the 100% success rate that we would like is because they're different diseases. We're treating them all the same. Posterior fossa decompression, even the type of decompression, as you know, is highly controversial. So when we start out with a diagnosis with lots of controversies already, and then you give it yet another controversy, it makes you think. So what evidence supports Chiari Zero? That's really the bottom line here. Well, the evidence is small. It's based on observational studies, first starting with 5 patients. Then Dr. Oakes' group extended it to 10 patients, 9 of whom had Syrinx improvement, 1 of whom stabilized. Another group reported 4 cases. They called it tight cisterna magna instead of Chiari 0, and found the same results. But then when you dig in deeper into these papers and into these patients, you find that they're not without any cerebellar or craniocervical abnormalities. A lot of them have defects in the arch of C1, where it could be attached to the occiput or it could be defective. There are intradural anomalies, like adhesions here in the foramen magnum that could be causing obstruction of flow. So you don't need the tonsils to be down to have obstruction of flow. So there are various abnormalities that started to emerge really when people looked at those in more detail. There are also abnormalities in the measurements. So for example, when Tubbs in 2001 looked at the anatomy of the posterior fossa and compared it to normal patients without Chiari 1, they found that in Chiari 0, the medulla is lower than in normal patients. That the distance and the AP mid-sagittal distance, which is this, is wider. And that the angle between the fourth ventricle and the clivus, this angle is abnormal. So these are not normal MRIs. And then Bogdanov in 2004 took it further in comparing Chiari or idiopathic syringomyelia with Chiari 1 and with normal patients, and again found that what idiopathic syringomyelia was closer to the Chiari 1 anatomy than it is to the normal anatomy. So it tells you there's something abnormal about that foramen magnum, even though the standard typical MRI that we get just doesn't show it. So the second question is, what could cause it? If it's there, what is it that is causing it? Well, there's no proof here, but except for some anecdotal selected cases. But some patients have an obstructive veil at the foramen of Magendie that obstructs the flow of CSF. Some have adhesions or scar tissue in here. In fact, when you look at post-operatively, Chiari 1 patients have been decompressed, sometimes years later. They develop arachnoiditis, adhesions there, and the syrinx recurs, even though you don't see a Chiari 1 anymore. The tonsils are not there, but you have adhesions. So the third question is Chiari 0 connected in any way to Chiari 1? Is there a familial relationship between them? And so you start out by looking at Millerat's paper and then others. Marcy Spear, who was actually the person that introduced me to ASAP. Marcy did a lot of genetic research in Chiari 1 and found, as a lot of the large studies are finding, is that there is a familial relationship, which means if you have a Chiari 1 in your family, you're more likely to have another Chiari 1 in the family. There's about a 10% familial relationship with Chiari 1. So starting with that, we wanted to see if those Chiari 1 patients also had family members with idiopathic syringomyelia or Chiari 0. And what we found 5 families that actually did that, where if you start out with the proband, which is the diagnosis we're taking is Chiari 1. So a patient with Chiari 1, do they have siblings or cousins with idiopathic syringomyelia or Chiari 0? And the answer is yes. There were several families that have that. But then when we look at those 5 families, we find that the Chiari 1 patient and the Chiari 0 or idiopathic syringomyelia patient have very similar anatomic changes in the foramen magnum. The obex is lower, the AP diameter is wider, the angle is different. So these are, if I'm Chiari 1 and my brother is Chiari 0, his anatomy of the posterior fossa is much more similar to mine than it is to a normal posterior fossa. The second thing we found is that the clinical presentation is very similar. So each one of these letters is one separate family. Actually, here they are. Sorry. Oh. Well, anyway, so for example, A is one family. I don't remember if these were siblings or cousins, but they both presented with spastic quadriparesis from Syringomyelia. C, the C family, they presented with claw hand. The D family, they presented with hyperreflexia and clonus. So the clinical presentation seems to be similar between Chiari 1 and Chiari 0. And then when you look at syrinx location, they also are very similar. So the A family, they're both cervical, cervicothoracic. Same with the B family. D were only thoracic, E was only thoracic. So this is this one's sibling, this is this one's sibling, and you can see. So anatomy is very similar. Third, of course, they both respond to posterior fossa decompression. Okay. So Chiari 1 and Chiari 0 share certain clinical and anatomical characteristics. The syrinx responds to posterior fossa decompression, hence the definition, and there is a familial aggregation. Okay. So what are the implications? Well, there could be a common pathophysiology. The syrinx that's caused by Chiari 1 may have the same pathophysiological mechanisms as the syrinx that's related to no Chiari 1. And perhaps this is related to a genetic basis, which means that the descent of the tonsils may not be essential to have Chiari pathophysiology and create Syringomyelia. But unfortunately, we don't have a diagnostic test to be able to separate right from the outset what is idiopathic syrinx and what is Chiari 0. So that's where we're stuck. So how do we make sense of all of this? What is said, there is nothing permanent except change. And the art of progress is preserve order amid change and preserve change amid order. So we just need to make sense of it. Otherwise, we're not going to go anywhere. The question is how to differentiate idiopathic Syringomyelia from Chiari 0. Both have no identifiable etiology. Chiari 0 responds to posterior fossa decompression, where idiopathic Syringomyelia is not supposed to, but there's no diagnostic test to differentiate them. In the background, we still don't understand the cause of Chiari 1, let alone Chiari 0. So how do we begin to understand variations of it like Chiari 0? Static MRIs that we have are unable to distinguish between these malformations. So we need more sophisticated MRIs, dynamic MRIs, CSF flows, better than what we have now. And we need to understand the genetics better, because there seems to be a link there. So what isn't Chiari 0? This is a child who presented with cough-induced headaches, hand numbness, swallowing problems, double vision. To all eyes, that's got to be a Chiari malformation. Except to say that, you know, if you add up all the neurology symptoms that we can ever find in a person, they amount to about 30. And there are thousands of diseases that have neurological consequences, which means that all these symptoms are shared by many, many diseases. So just having these symptoms doesn't necessarily imply that there's a Chiari malformation. In fact, this is the patient's MRI. It's normal. So part of the controversy is that there are physicians out there who call this Chiari 0 and the absence of Syringomyelia because of the symptoms. That takes the controversy to a much higher level. and it shouldn't happen. So, the answer is there's no Chiari 0 without syringomyelia. Why? Because symptoms are subjective. A syrinx is objective. You can see it. There's no diagnostic test to differentiate them. So, which means that the diagnosis of Chiari 0 is suspected preoperatively, but can only be proven postoperatively. So it's a circular argument. Chiari 0 is a rare bird. I see one every 2 or 3 years, not more than that. We have to be careful with rare birds. If you get a patient with a syrinx in the spinal cord, you have to get a full brain and spine MRI with and without gadolinium, because you need to make sure that there's nothing there that causes it. In this particular patient, there was a tumor higher up. In this patient, there's a lipoma, tethered cord. So, thank you very much.